Good evening, students. Welcome to you from Sri Rama Hospital, Jagaipet. We are discussing on the pancreatitis. In the previous class, we learnt about acute and chronic pancreatitis, and today let us study about the pseudopancreatic cyst. What is the definition of cyst? Before we discuss about pseudopancreatic cyst or pseudocyst of the pancreas, so please tell me what is the definition of a cyst? What is a cyst? Fluid-filled swelling. No, it is not completely correct. Pus-filled swelling means it is abscess. No, it is also. What is a cyst? Any fluid collection is not called as a cyst. Localized collection of fluid which is lined by healthy granulation tissue. This is also incorrect. This is a definition of a pseudocyst. The definition of a cyst is localized collection of fluid lined by epithelium or endothelium. So that is the definition of a cyst. So some fluid must be collected and it should be lined by a wall, and that wall should have some epithelium or endothelium. So that is the that is a cyst. So we are going to deal with a pseudopancreatic cyst. What is the definition? It is defined as a localized fluid collection that is rich in amylase and other pancreatic enzymes that have a non-epithelialized wall. So it has no epithelium in the wall, and the wall consists of fibrous and granulation tissue. So that means it is not a true cyst. A true cyst means it should have epithelium or endothelium. Because it has no epithelium, that's why it is called as a false cyst. The cyst collects in the peripancreatic tissue around pancreas and not in the pancreas proper. Hence, it is called pseudopancreatic cyst. That means it looks as if it is in the pancreas, but it is not in the pancreas. It is in the surroundings of the pancreas. It is also called as pseudocyst of the pancreas because there is no epithelial lining for the cyst. It has only a fibrous wall with granulation tissue. That is why it is called as the pseudocyst of the pancreas. What are the causes? The causes being acute pancreatitis. Usually, the cyst resolves in 1 to 6 weeks' time. Blunt abdominal trauma due to disruption of the pancreatic ducts or ductules. There will be formation of the cyst in 2 to 3 weeks' time after trauma. In children, pseudocysts and trauma are frequently associated. The third cause is chronic pancreatitis. So how the cyst forms? Disruption of the ductules or ducts due to trauma or inflammatory necrosis. So whatever it is cause, if there is necrosis or disruption of the ducts or ductules, there will be liberation of enzymes. And these pancreatic secretions, they accumulate surrounding the pancreas where there is ductal damage. Because of the accumulation of these secretions, there will be inflammatory reaction and encapsulation with fibrosis. This is called the pseudocyst. So the pseudocyst is nothing but collection of enzymatic secretions and debris around the pancreas. And because of its presence, there will be inflammatory reaction followed by granulation tissue formation and capsulation. So pseudocyst means it contains fluid which has a lot of pancreatic enzymes and also some necrotic pancreatic tissue walled off by fibrosis and granulation tissue. So this is the pancreas. This is the lesser sac. Already I told you about the boundaries of the lesser sac. Anteriorly is bounded by the left lobe of the liver. Then gastrohepatic omentum, that's called the lesser sac. Then posterior wall of the stomach. Then the greater momentum anterior layer. The posterior boundaries being posterior abdominal wall, pancreas, posterior leaf of the transverse mesocolon, transverse colon, and posterior leaf of the greater momentum. To the right, lesser sac has what? To the right of the lesser sac, what structures are there? Tell me only one structure that is important. To the right of the lesser sac, there is an opening. There is an opening. Yes, that is foramen of Winslow, through which it communicates with the greater sac. What is the boundary on the left side? The boundary on the left side is spleen. So the fluid can collect in the lesser sac. So there will be formation of fibrous tissue and granulation tissue around the fluid collection. That is why the whole lesser sac is not enlarged here. So a part of the lesser sac may get the fluid encystment. So the encystment can be just behind the stomach. That means between the stomach and pancreas, like this. These fluid collection to be distinguished from acute fluid collections, organized necrosis, and abscess. So in acute pancreatitis, so these things also happen in around the pancreas. That means there can be fluid collection, there can be organized necrosis, there can be abscess. Acute fluid collections usually have an irregular shape and lack a well-defined wall. In general, they resolve in about 65% of the cases. So in the previous class, I told you about this acute fluid collection in acute pancreatitis. So this occurs in moderate and severe acute pancreatitis. Organized necrosis appears cyst-like on CT scan, but it appears to be solid on other imaging modalities. Abscess is an infected area of necrosis or infected area of fluid collection. So around the pancreas, due to acute pancreatitis, there can be these formations. They should not be confused with pseudopancreatic cyst. Pseudopancreatic cyst is nothing but collection of fluid containing enzymes of the pancreas surrounded by thick wall of fibrosis having granulation tissue. In acute fluid collection, there is only fluid collection, but there is no fibrotic wall. So this is nothing but edema fluid around pancreas. Sometimes the fluid will be very large in quantity and manifest like a fluid collection there without a wall. The necrosis sometimes can be seen as a cyst on CT scan, but it is not a true collection of fluid. So the necrotic area or the fluid may be infected, forming an abscess. So this is different. This is not a pseudopancreatic cyst. This is an abscess of the pancreas. It may be single or multiple. Multiple cysts are more frequently observed in patients with alcoholism. The fluid in pseudocyst has been well characterized as clear or watery, or it can be xanthochromic. The fluid usually contains very high amounts of amylase, lipase, and trypsin, though the amylase level may decrease over a period of time. 2/3 of patients Of course, I will tell you about differentiation between the abscess and pseudocyst in the clinical features as well as the investigations later. 2/3 of the patients have demonstrable connections to the pancreatic duct. So there will be communication with the pancreatic duct. So the pseudocyst usually occurs because of leakage of large quantity of pancreatic enzymes. It is not by seepage of enzymes. It is a collection of large quantity of enzymes. So this large quantity of enzymes will be there in cases of the injury to the duct. So that is why the cyst will be having communication with the pancreatic duct in about 2/3 of the cases. In the other 1/3, an inflammatory reaction is supposed to have sealed the connection so that it is not demonstrable. So in 2/3 of the patients, you will find communication with the duct. In 1/3, there is no communication. But in that 1/3 also, probably it is due to communication with the cyst and the duct. But later, the communication has been shut off because of fibrosis as a result of inflammatory reaction. So there are two types communicating cysts. That means those which communicate with the ductal system of the pancreas. They are cured by internal drainage. Non-communicating cysts, where the communication has been blocked by development of fibrosis. So these are cured by aspiration or by watchful expectancy. Watchful expectancy means if you just keep them on observation, they gradually resolve because there is no communication with the ducts. So those which are having communication with the ducts, they do not heal. As such, they need to be operated upon. Site, the cyst can form in this lesser sac behind the stomach or in the lesser momentum. That means the stomach is displaced down between the stomach and liver. It bulges. So it presents like a cystic mass between the stomach and the liver through the lesser momentum. Or between the stomach and transverse colon. Sometimes it may project here. That means in this region between stomach and transverse colon also sometimes it may bulge like this. Or around the head of the pancreas, around the tail of the pancreas. So if it is between the stomach and transverse colon, it will be like this. So there will be encystment of fluid either in the lesser sac or in the head of the pancreas or in the tail of the pancreas. So it can be there in the head of the pancreas. Number of cysts usually single. In 15% of the cases, multiple. Usually multiple are seen in the alcoholics. Complications of the cyst, infection leading to abscess and sepsemia. Rupture. it can rupture into the adjacent gut to which it is adhered. So because of the fibrous reaction or fibrosis or chronic inflammation, it gains attachment to the posterior wall of the stomach or sometimes to the duodenum. If it is head of the pancreas, it will be adhered to the duodenum. Or if it is tail of the pancreas, it may be adhered to the transverse colon or to the small bowel. So it may rupture into those structures, into the alimentary tract or into the peritoneum. Sometimes there may be hemorrhage from the surrounding blood vessels. Already we have seen 2 blood vessels can cause hemorrhage in acute pancreatitis. What are those 2 vessels which cause bleeding? Yes, GDA and what other vessel? Yes, very good. Splenic artery. So gastroduodenal artery and splenic artery are, yes, very good. The same ones are also responsible here for hemorrhage. The hemorrhage can be into the cyst or into the peritoneal cavity. Sometimes the cyst may be very large and may produce pressure on the common bile duct or bowels, especially on the duodenum, producing obstruction to the alimentary tract. Clinical features: age, middle age, sex, usually males are more commonly affected, just like acute pancreatitis and chronic pancreatitis. Patient may manifest with a lump in the upper abdomen. The smooth form may be tender. If the inflammatory reaction has subsided, it is not tender. If some inflammatory reaction is present, then it will be tender. It doesn't move with respiration. Now just I will discuss few points about the movement with respiration of a lump in the abdomen. What lumps in abdomen move with respiration? What are the lumps which move on respiration? Because in the clinicals, whenever you get a case of lump in the abdomen, the examiners usually ask you to tell about movement with respiration, is present or not, because there is a valuable sign by which you can differentiate certain swellings. So what are they? Which swellings? Okay, I will explain here. All the swellings which are related to the diaphragm, because dome of the diaphragm is there. So if a lump is there just under the dome of the diaphragm, during respiration or inspiration, the diaphragm comes down. So the swellings which are related to diaphragm will move down with respiration. So the diaphragm should push it, and the movement must be transmitted to the lump. Then only it moves down. So the first feature is the lump must be related to the diaphragm. That means it should be arising from a structure or an organ which is having relationship to the diaphragm. Example being the liver, the spleen, the stomach. And second feature of the swelling is the swelling should be arising from an organ which is freely mobile. Which organs are mobile? Those organs which are surrounded by the peritoneum on all sides. That means intraperitoneal organs. So all the intraperitoneal organs which are related to the diaphragm move down with respiration. So examples being swellings arising from the liver, from the spleen, from the stomach, and the swellings arising from kidneys also move down with respiration. Kidney is not an intraperitoneal structure, but it moves on respiration. Why? Because kidney is enclosed in three capsules: a true capsule, a fatty capsule, and a facial capsule. So within the facial capsule, the kidney has some slight movement. That means it is mobile and it is related to the diaphragm. So when our patient takes deep inspiration, the diaphragm pushes the kidney to a slight extent because of its slight mobility. So kidney swellings also move down on respiration, but their movement is not as much of that of the liver or spleen. The liver and spleen swellings, they move more when compared to kidney swellings. Pseudopancreatic cyst. Though it is situated in the lesser sac, it is not mobile because of the chronic inflammatory reaction. It gets adhered to the surrounding structures. So it is not mobile. It is adherent to the underlying posterior abdominal wall. It is adherent to the pancreas. Anterior, it is adherent to the stomach, to the lesser momentum. Above, it is adherent to the liver. Below, it is adherent to the transverse column. So all these structures, they are adherent to the pseudopancreatic cyst. So the cyst is not mobile. So it doesn't move with respiration. There will be transmitted pulsations of aorta when you examine the mass. How do you differentiate transmitted and expansile pulsations of aorta? For example, a mass is there in the epigastric region. When you are pressing the mass, or when you keep your hand and just apply slight pressure, you will feel the pulsations. So all these pulsations are called transmitted pulsations or expansile pulsations. So this can be from a pseudopancreatic cyst or this can be from a abdominal aortic aneurysm. So how do you differentiate between transmitted and expansile pulsations of aorta? That means how do you differentiate between pseudopancreatic cyst and abdominal aortic aneurysm? That finger test, two finger test, is not applicable in the abdomen because the aorta is situated very deep. So you cannot demonstrate the expansile pulsation. How do you differentiate between pseudopancreatic cyst and aortic aneurysm? This is one of the favorite questions of the examiners. In the clinicals, they will definitely ask you whenever a case of pseudopancreatic cyst is given to you. So pseudopancreatic cyst is a very commonly given case in the examination. Whenever you see epigastric lump, so you have to think of pseudopancreatic cyst also a possibility. So examiner will definitely ask you, did you examine for the pulsations? Then he will ask you, is it a transmitted or expansile pulsation? Okay, none of you are correct. I will explain. Suppose this is the abdominal aorta. On this, a mass is kept. A spherical mass is present. And the pulsations of the aorta are transmitted, so you can feel the pulsations even if the mass is not arising from the aorta but situated over the aorta. So how will you say that it's transmitted pulsation? It is not an expansile. Expansile means the mass itself is completely expanding, as in aortic aneurysm. So usually, if it is there on subcutaneous mass, you do the two-finger test. You place two fingers over the mass and closely observe your fingers. In case of transmitted pulsation, the fingers are just lifted up. In case of expansile pulsation, the fingers are lifted as well, they are separated. So they will be moving like this in expansile pulsation. In transmitted pulsation, the movement will be straight upwards, 90 degrees like this. That is for a mass in the subcutaneous region where you can feel this finger test. But for a pulsations coming from a deep place situated abdominal aorta, then this test is not applicable. So what you do is you examine the patient in supine position and watch for the pulsations. Then ask the patient to turn to knee elbow position. Then feel the mass. If the mass is not from the aorta, but it's situated just in front of the aorta in knee elbow position, what will happen to the pulsations? Will the pulsations be present or absent? If the mass is densely adherent to the aorta, then the pulsations will be present. If the mass is not adherent to the aorta, then pulsations will not be present, because this is the aorta. For example, suppose this is the aorta, the mass is here. So when you make the patient to be in knee elbow position, the mass just separates away from it will not sit over the aorta. It will be placed little away from the aorta if it is not adherent. That is why the pulsations will disappear. But if you push the mass back against the post-abdominal wall, then you can feel the pulsations. But just if you keep your hand over the anter-abdominal wall and over the mass and just observe, there will not be any pulsation. But if you just push it back, then you can feel the pulsations. In case of pseudopancreatic cyst, if it's abdominal aortic aneurysm, whether the patient is in supine position or in knee elbow position, there will be no change in the pulsations. They are felt equally. Did you got this point? Is it clear? All these clinical tests you must be very much aware of, and you must demonstrate. If the examiner asks you to demonstrate these tests, you must be able to demonstrate. That's why once the lockdown is over, and when you go to the hospital, and when you find a case of lump in the upper abdomen, look for these transmitted and expansile pulsations. Even the case is not there in surgical wards, you can go to the gastroenterology department and then you can inquire the postgraduates there. They will help you to find a case of pseudopancreatic cyst. Then you can look for these pulsations. This is very, very important sign. Transmitted pulsations of aorta. Lump may be felt in the right or left hypochondrium also, depending upon whether it is arising from the pancreatic head or pancreatic tail. If it is for the body of the pancreas region, it will be in the midline. If it is for the head, it will be felt in the right upper quadrant of the abdomen. If it is on the tail, it will be towards the left upper quadrant of the abdomen. So apart from lump, the other manifestations can be persistent abdominal pain, anorexia, or abdominal mass after an attack of pancreatitis. The patient gives clear history of pancreatitis, and following that, usually 4 to 5 weeks later, you will find the mass. Physical examination may reveal tender abdomen, palpable mass in the upper abdomen, transmitted pulsations. Peritoneal signs suggesting rupture of the cyst or infection. So when the cyst gets infected and forms an abscess, what signs will be there? There will be fever, icterus, pleural effusion. So whenever you find a lump along with jaundice, along with fever, raised pulse rate, or along with pleural effusion, you must suspect either rupture of the cyst or infection. So this is how Clinically, you differentiate between an uninfected pseudopancreatic cyst and infected or abscess of the pancreas. Pancreatic abscess can develop for two reasons. Number one, it can occur following infected necrosis becoming abscess. Infected necrosis means a stage of acute pancreatitis. So acute pancreatitis, infected necrosis, abscess formation. That is the commonest formation. The second way how abscess can occur is a pseudopancreatic cyst may be secondarily infected and can form an abscess. So whenever abscess is there, then there will be signs of infection. Signs of infection will be general signs of infection in form of fever, tachycardia, malaise, etc. And local features of infection in form of severe tenderness and pain. The jaundice will be there because of associated reactionary inflammation of the liver. So whenever there is infection in the cyst, so adjacent liver also may get hepatitis. So that's why it produces jaundice. That jaundice also is mild jaundice. Differential diagnosis, that means a mass in the upper abdomen or right or left upper quadrants. So whenever you find spherical masses, so what should be the other things you must consider? It may be capsis, hydroid cyst, or solid mass from the liver. Solid mass from liver means, what is solid mass from liver? Yes, it is HCC, hepatocellular carcinoma. Then you have to think of carcinoma of the stomach, retroperitoneal mass. What is retroperitoneal mass? Retroperitoneal mass means a mass arising from retroperitoneal mesenchymal tissues. So what mesenchymal tissues are there in the retroperitoneum? What? So that is from kidney. Kidney masses are not considered as retroperitoneal masses. Retroperitoneal masses means from the mesenchymal structures of the retroperitoneum, not from the organs. The organs are specifically called as pancreatic masses or kidney masses or adrenal masses. So apart from the organs, there are mesenchymal tissues. So what mesenchymal tissues are there? The fibrous tissue, that means in form of sheath of the muscles, intermuscular septa, then adipose tissue. So the fibrous tissue and adipose tissue, they can form tumors. So what tumors? They can form fibrosarcoma or liposarcoma. So retroperitoneal masses means due to neoplasms, mainly retroperitoneal fibrosarcoma or retroperitoneal liposarcoma. The other things being cysts in the retroperitoneum. So retroperitoneal mass can be a cyst due to cyst. The cyst can be due to paramesonephric duct remnants or mesonephric duct remnants, or due to the mesenteric cyst bulging into the retroperitoneum. So then the next differential diagnosis is mesenteric cyst, aortic aneurysm. So aortic aneurysm is clinically differentiated by expansive pulsations. We have to differentiate it from the true cysts of pancreas. That is very, very important. What are the true cysts of the pancreas? Organized pancreatic necrosis, acute pancreatic fluid collections, then neoplasms. The neoplasms of the pancreas being neoplasms, cystic neoplasms, serous cystadenoma of the pancreas, mucinous cystadenoma of the pancreas, mucinous cystadenocarcinoma, then pancreatic retention cyst. So these are all the cysts that can occur in the pancreas. So these are called the true cysts. Pseudopancreatic cyst, it doesn't occur in the pancreatic parenchyma. It occurs just around the pancreas, either anteriorly most commonly or posteriorly. The true cyst must be differentiated from pseudocyst by endoscopic ultrasonography and aspiration of the fluid from the cyst, and examine the fluid for carcinoembryonic antigen, then amylase content, and for malignant cells. Pseudopancreatic cyst has low levels of carcinoembryonic antigen and high amylase. Neoplastic cyst has more than 400 nanograms per ml of CEA and low levels of amylase with presence of malignant cells. So by this FNAC test, you will be able to differentiate between pseudopancreatic cyst and the neoplastic cyst. So these are some of the cysts around the pancreas. So this is a pseudopancreatic cyst arising at the tail region of the pancreas. This is mucinous cystic neoplasm, where the cyst is filled with thick mucinous substance. This is called IPMN, that is intraductal papillary mucinous neoplasm. This can be from the main duct or this can be from the side branch. Another is the serous cystic neoplasm, where you can see multiple cysts, multiple small cysts. They will be aggregated, and it is described as the bubble wrap masses. You know, for the packing of some material, so when you order online, so you'll get the material. So in the box, that material will be packed by bubble wrap paper. So just like bubble wrap paper, these cysts will be there. That's why this is called the bubble wrap cysts. This is serous cystadenoma of the pancreas. So there will be multiple small cysts. They are all gathered into a big mass. So this is the cystic neoplasms of the pancreas. Investigations. Number 1, serum amylase estimation. We have already seen serum amylase will be elevated. Tell me the rule of 4 regarding serum amylase. What is rule of 4? Serum amylase. No idea? How do you know it? Elevate by 4 times, rise in 4 hours, and gets to normal in 4 days. That's fine. Good. So by 4th day, the serum amylase decline in acute pancreatitis. Then what about serum amylase levels in chronic pancreatitis? Are they raised or not? In chronic pancreatitis. Yes, they are not raised. There will be slight rise in the chronic pancreatitis. So similarly, the pseudopancreatic cyst occurs on usually from 3rd to 6th weeks of acute pancreatitis. That is why the amylase is not elevated. If pseudopancreatic cyst develops as a complication of acute pancreatitis, amylase levels are elevated in about a week in convalescent phase. That means acute pancreatitis in 4th day, the amylase levels will fall in acute pancreatitis. And if pseudopancreatitis develops further such case, then they will be slightly elevated and then it falls again. So in the early phase of formation of pseudopancreatic cyst, you can find elevated serum amylase. But when it gets matured with a thick fibrous wall, then serum amylase will not be elevated. Plain X-ray abdomen, it may show calcifications. If it is a very old cyst, there may be calcifications in the wall, and it will show a soft tissue shadow. There is not of much use. Ultrasound scan of the abdomen, it can show the presence of the cyst, its size, and its proximity to the pancreas. So it can show a cyst mass there, but actual anatomy and its relations cannot be well understood with ultrasound scan, because the pancreas is situated very deep in on the posterior abdominal wall. So it's covered by the stomach, which is filled with air, and bowels, which are filled with air. That is why you cannot appreciate much of the pancreas. Cystic mass can be made out, but its relationship with the pancreas and other bowels can't be made out clearly on ultrasound scan. So whenever a patient is having a lump in the abdomen, in the upper abdomen, you can do ultrasound scan, which will show a anechoic or hypoechoic mass in relation to the pancreas. Then you have to go for the CT scan. It is helpful to define the exact size and relations of the cyst. So whether it's situated in the head of the pancreas, whether the duodenum is compressed or not, or stretched, or whether it's situated in the tail of the pancreas. So these things can be made out on CT scan. And CT scan is helpful to evaluate the underlying pancreatic disease. We have already seen that pseudopancreatitis can develop due to trauma, due to acute pancreatitis, or due to chronic pancreatitis. So already we learned about the CT scan findings in acute pancreatitis as well as in chronic pancreatitis. So CT scan will help us to evaluate the condition of the pancreas. It also helps us to differentiate pseudocysts from the true cysts of the pancreas. The pancreas may appear irregular or have calcifications in chronic pancreatitis. Pseudoaneurysms of the splenic artery are bleeding into a pseudocyst, biliary and enteric obstructions, and other complications may be noted on CT scan. The CT scan provides a very good appreciation of the wall thickness of the pseudocyst, which is useful in planning the therapy. So when you plan about surgical management, then I will tell you about this point, about wall thickness. CT scan, what are the features of pseudopancreatic cyst? Unilocular cyst without solid component, without central scar, or without any calcifications in the wall. There may be slight debris within the cystic lesion. It may be found in any part of the pancreas or anywhere within the abdomen, and sometimes even in the chest. The features of cystic neoplasm. So if it is a cystic neoplasm on CT scan, how it appears? Thick, irregular wall, septations, solid component in the cystic mass, dilated pancreatic duct more than 3 millimeters, and calcifications. This is a pseudopancreatic cyst. All this granular material is the debris, necrotic debris. This white rim is the wall of the pancreas, wall of the cyst. You can see again here is the pseudopancreatic cyst. And this is the liver, this is the stomach. So actually this is a coronal CT scan. This is not an axial CT scan, it is a coronal CT scan. You can see stomach is displaced upwards, and if you see it down also, you can see transverse colon will be pushed down. That means, I told you, the pseudocyst of the pancreas can present behind the stomach, that means between the stomach and pancreas, somewhere here. Or it may present between stomach and liver, or it may present between stomach and transverse colon. So if you just recall the anatomy of the lesser sac, you will understand this point, how it can manifest like that. Of course, I already explained to you in the anatomy. This is a pseudopancreatic cyst in the tail of the pancreas, and this is a pseudopancreatic cyst. Sorry, this is a cystic neoplasm of the pancreas, again in the tail of the pancreas. You can see the spleen here. This is the cystic mass. So surrounding is the solid component. In center is the cystic mass. So solid plus cystic both will be there in case of neoplasm. Sometimes you can find septations also. But here you can see uniformly it is made of only cystic mass, but having some debris inside. So the most useful investigation in the diagnosis of pseudopancreatic cyst is the CT scan. Then endoscopic ultrasonography and aspiration of the fluid for cytology, CEA, and MLH estimation. Already I explained this point to differentiate pseudocyst from the true cystic mucinous tumors of the pancreas. Pseudocyst has low CEA, high MLH, and inflammatory cells on cytology. Mucinous tumors have high CEA, more than 400 nanograms per ml, low MLH, and typical mucinous cells on cytology. ERCP. You have done CT scan, you found the cyst in relation to the pancreas, and it is a pseudopancreatic cyst. Then why do you want to do ERCP at all? When you observe cystic mass in relation to the pancreas, then why do you want to do ERCP? Just think about and then tell me. What for you need to have ERCP? Yes, very good. Very good. Whether it's communicating cyst or non-communicating cyst. Very good. To know about the ductal communication. To know the anatomy of the ducts and to reveal communicating cysts for proper planning of surgery. Barium X-ray lateral view, it was a old investigation which is not being practiced nowadays. But sometimes in your vivavos, they may give you an X-ray of the barium meal and will ask you to read that X-ray, and probably that may be a pseudopancreatic cyst. That is why I am putting this here, but this investigation is not being done nowadays. Please remember that. Just to make you aware of this barium X-ray, I am showing this X-ray here and explain this point. There will be increased retrogastric space of more than 2.5 centimeters. Normally it's about 1 centimeter. What is this retrogastric space? If you give barium meal, the barium will come and fill the stomach. Normally, the space will be only this much. You're seeing this is the posterior border of the stomach, upper border of the stomach here. So this is a lateral view. These are the vertebral column. So these are the spines. These bodies are the vertebra. And between the bodies of the vertebra and posterior border of the stomach, that is, the barium fills the stomach. So the gap will be only usually around 1 centimeter. But if some space occupying lesion is present behind the stomach, then what happens? The stomach will be displaced anteriorly. So the distance will be more. This is called the retrogastric space. So the retrogastric space is increased. So this indicates that there is a pseudocyst in the pancreas. So I already told you there will be correction of fluid in the lesser sac with encystment. So this causes displacement of the stomach forwards. So there will be this retrogastric space increase. And also in AP view, you can see the lesser curvature is being displaced down. It's pushed down. This is because there is a small mass here. So this is an indirect evidence of this mass lesion here. We can't say definitely whether it is a cystic mass or a solid mass. There is a mass on the lesser curvature of the stomach which is being displaced down. That means here probably there is a mass in the lesser momentum which is displacing this stomach lesser curvature downwards. So Bayer meal gives you an indirect evidence of the presence of the mass. That won't tell you whether it's a cystic mass or a solid mass. So these are the investigations. So the main investigation is CT scan, then endoscopic ultrasonography, and there you can aspirate the fluid from the cyst and examine for amylase contents, CEA, and cells. By that you will differentiate pseudocyst from the true cyst of the pancreas. If it is an abscess, then if you aspirate, you will get pus, and the pus can be sent for culture tests, and you can give the treatment, and you can drain the abscess. What is sequelae of pseudopancreatic cyst? Resolution occurs in 60% of the cases in 6 weeks' time. So usually this resolution follows due to fibrosis of the communication. So for example, duct is there, pancreatic duct. It is communicating with the cyst. Now this communication is also gets fibrosed. That means it becomes non-communicating. Then the fluid in the cyst gradually gets absorbed and the cyst will dissolve. Chronic cystic mass with fibrotic wall. Infection leading to abscess. Obstruction of the bile duct by the cyst in the head of the pancreas, producing jaundice. Bleeding into the cyst. The wall of splenic artery may get digested by the enzymes, and hemorrhages may occur into the cyst from the pseudoaneurysm that is formed. Rupture. It may rupture the peritoneal cavity or other viscera like stomach, duodenum, transverse colon, small bowel. Management of the pseudocyst. Indications for intervention. Symptomatic cysts, that means where there is pain, anorexia, discomfort, a large mass. Cysts with complications. In some cases, to differentiate from true cystic neoplasm. If endoscopic ultrasonography fails to differentiate between a true cyst and a pseudocyst, then you have to do surgery to differentiate it. Cysts more than 6 centimeters in diameter. Cysts which stay for more than 6 weeks' time. The procedures, there are 3 procedures. One is surgery. The other is endoscopic drainage. The third one is external drainage. External drainage is percutaneous drainage. The percutaneous drainage, endoscopic drainage, and surgery. Surgery may by open or laparoscopic methods. Percutaneous drainage, it is done under guidance of ultrasound scan or CT scan. So you do ultrasound scan or CT scan, visualize the cyst, and then you puncture the cyst, aspirate it, or you pass a tube. It is done only in the non-communicating type. Otherwise, if there is communicating cyst is there will, because of communication with the pancreatic duct, there will be continuous leakage of pancreatic enzymes into the cyst cavity because you put a drain, so it results in a fistula, pancreatic fistula. Sometimes you may miss neoplastosis by this particular procedure. High recurrence rates, hence it is not practiced. Endoscopic approach. Endoscopic, that means endoscopic ultrasound guided drainage of the cyst into the stomach or jejunum. So you pass the endoscope into the stomach. Usually the cysts are related to the stomach posterior wall. And because of the chronic inflammatory reaction, stomach gets densely adherence to the cyst. So you do the scanning where you find such thick adhesion between the cyst and stomach wall. At that place, you puncture the cyst. aspirate the fluid, pass a guide wire, and over the guide wire you pass a stent and leave it there like that. So all the fluid that is there in the cyst will now drain into the stomach and the cyst will collapse. Neoplastic cyst should be excluded before this procedure. That is, first you do endoscopic ultrasonography, aspirate the fluid, test for MLH, CEA, and cells. If there is no proof of neoplasm, then you do endoscopic drainage. The other procedure is endoscopic retrograde cholangiopancreatography, and pancreatic stenting of ampulla may help to drain a communicating cyst into the duodenum. So if you put a stent, so the communicating cyst may drain directly into the duodenum and it may collapse. Surgery, the principle of surgery is cysts of more than 6 weeks standing gets a thick fibrous coat. And this fibrous coat, because of chronic inflammatory action, will be adherent to the neighboring viscera. Hence, the cyst can be anastomosed to the viscera to provide drainage in the communicating cyst. So already I told you, during CT scan, you evaluate the thickness of the wall of the cyst, and that will help you to plan the surgery. If the wall is very thin, then you don't do surgery. You wait till the wall gets matured and becomes thick fibrotic wall, at least more than some 4 mm or 5 mm thickness. If the wall is thick, then if you do anastomosis between the stomach anteriorly and the cyst posteriorly, so the cyst wall can hold the sutures well. If the wall is very thin, it will be fragile. So if you take the sutures, they will cut through. So what you do is you wait till the cyst is of more than 6 centimeters in diameter, the wall is more than 4 millimeters in thickness, then you go for surgery. So that is the meaning of waiting for 6 weeks. Of course, non-communicating cysts can be managed by aspiration or by watchful expectancy. They will resolve on their own. So for all communicating cysts, you have to do anastomosis between the cyst and neighboring viscera, which is adherent to the cyst. It may be the duodenum, it may be the stomach, it may be the jejunum. For example, if a pseudopancreatic cyst is here, then you can anastomose to the stomach. If a pseudopancreatic cyst is there in the head of the pancreas, you can anastomose to the second part of the duodenum or third part of the duodenum, which is adherent to the cyst. If it's tail of the pancreas, you can do anastomosis with the jejunum. So when you do anastomosis with the stomach and cyst, it is called the cystogastrostomy. If you do anastomosis between the cyst and the jejunum, you call this as cystojejunostomy. Here it is called the cystoduodenostomy, and here it is the cystojejunostomy, or you can even resect the tail of the pancreas. So the procedures are cystogastrostomy, commonly done. It is done for the cyst abutting onto the stomach and adherent to its posterior wall. Cystojejunostomy. It is done for cysts in the body and tail without having addition to the stomach. For patients with chronic pancreatitis with ductal obstruction, longitudinal pancreatitis can be clubbed. That means, I have told you, we will do an operation called longitudinal pancreaticojejunostomy. What is the other name for this operation? What is the other name for longitudinal pancreaticojejunostomy operation? Oh, wonderful. It's called the Pustos operation. So you take a Roux-en-Y loop and then anastomose to the pancreatic ducts. So if a pseudopancreatic cyst is there, then the same loop can be anastomosed to both the duct as well as to the pseudopancreatic cyst. I hope you can imagine. Otherwise, I will draw a diagram and tell you. I hope you don't need any diagrammatic explanation. Yes or no? Okay. Cystoduodenostomy for cysts abutting onto the duodenal wall. So these are the three types of procedures you do. This is cystogastrostomy. You open the abdomen, expose the stomach, anterior stomach. You make an opening in the anterior wall of the stomach. Then you will see a bulging mass through the posterior wall of the stomach. So you puncture it and aspirate the fluid. Then make the incision at least up to 6 centimeters in length. Then you anastomose the stomach wall to the cyst wall. So before you do the anastomosis, what you should do is you must take biopsy at multiple places from the cyst wall. So cyst wall biopsy has to be taken, because afterwards, if you get the histopathology report as a cystic neoplasm, then you must revise your operation for removing the cystic neoplasm. So you can see the cyst here. This is the pseudopancreatic cyst. So this is called the cystogastrostomy operation. And once you do the anastomosis, then you close the anterior wall of the stomach. For some reasons that are not understood, after cystogastrostomy, we will find that the food will not enter the cyst cavity. Cyst fluid only will come into the stomach cavity. Probably this is influenced by the peristaltic activity and tone of the gastric wall. But exact cause is not understood. So sometimes in examination, the examiner may ask you how the food won't go into the cyst wall, cyst cavity. So you can boldly say the mechanism is not understood. We do not know. So don't say I don't know. Then the examiner will think that you don't know the answer. So that's why you just say the mechanism is not well understood. That's what you have to say. Distal pancreatic resection. It is done for the cyst in the tail of the pancreas. So biopsy of the wall of the cyst is done in all procedures by excising a small wedge of the cyst wall to exclude the tumor. So this is about pseudopancreatic cyst. Any doubts? If you have no doubts, I will go to the other topic. Cystectomy operation is a difficult operation because cyst is adherent to the surroundings, so very many structures, to the blood vessels, to the pancreas, etc., etc., etc. So that is why removal of the cyst is difficult. If it is a neoplastic cyst, there will not be much additions to the surrounding structure. So if the tumor has not infiltrated, so you can remove the mass along with the pancreas. But if it is not adherent, means you have to wait. That is why CT scan will help you to know about thickness and then how much it is adherent to the stomach wall. So by that only you have to plan your surgery. If the gap is there between the cyst wall and the stomach, wait till the patient gets that adhesions. So once you find a cyst, immediately should not go for surgery. You have to evaluate it. The patient is having severe pain, and if he demands surgery immediately, then it must be due to the associated pancreatitis, chronic pancreatitis. So in that case, you must be very careful to advocate surgery for the patient. Because if it is a case of chronic pancreatitis and if you do surgery, the patient may not get relief for pain, because this chronic pancreatitis is because of fibrosis of the ducts and parenchyma. So that will cause pain. So that is not going to be relieved by doing surgery for the pseudopancreatic cyst. So you must warn the patient about that and you must do surgery. Yes, at least the wall should be having minimum of 4 mm thickness, and it should be quite close to the stomach, duodenum or small bowel. So whenever it is adherent or very close with thick wall, then only you do surgery. Otherwise, you don't plan for surgery, you wait. If the patient is having a lot of pain, you can do a endoscopic ultrasonographic transgastric aspiration of the cyst. 60% of the cysts which have very thin wall, they will resolve on their own. That's why you need not operate upon them. Yes, if pseudopancreatic cyst is obstructing common bile duct, we wait for it to drain into the viscera. We have anastomosis into. No, for example, now this is the pancreas, let us suppose. There is a pseudopancreatic cyst in the head of the pancreas like this. So this is all the pseudopancreatic cyst. And the common bile duct coming from here. It gets compressed by this cyst. Now once you drain this cyst into the duodenum, by doing a duodenocystostomy, because it is abutting on the duodenum here, for example, third part of the duodenum. So you do the anastomosis between the cyst and duodenum. All the fluid will drain into the duodenum. Then this compression will be released. So jaundice will subside. So you don't anastomosis into the common bile duct. You anastomosis into surrounding viscera like stomach or duodenum or small bowel. Never into the common bile duct. Is it clear? Cyst will keep filling because it is communicating with the duct. You do surgery for the only cysts which have communication with the duct. If there is no communication with the duct on ERCP, you don't do surgery. You wait. Or if the patient is having symptoms like pain, you do transgastric aspiration with endoscopic ultrasound. So because it is communicating with the duct means continuously the enzymes are flowing into the cyst and they are draining into the stomach. The cyst wall is thin and causing obstruction to the common bile duct. Then what do you do? Then what we have to do is we have to aspirate the cyst. Then the obstruction will be relieved. In a communicating pseudocyst, the obstruction CBD will be relieved immediately after the cyst is anastomosed to the duodenum, because all the contents will empty suddenly into the duodenum. So the cyst will collapse before your eyes. When you are doing surgery, when you anastomosing the thing itself, you will see all the fluid will be coming out into the duodenum. That's why the cyst will completely collapse within seconds. So the duct will be relieved of the pressure. So it won't take much time for it to get relieved of the pressure. The CBD obstruction is mainly because of the displacement, because the duct is like this cyst will push it like this. So because of that, the cyst gets distorted, the CBD will be distorted and gets obstructed. Once you drain the cyst, then CBD assumes normal position and distortion is not there, and it will have normal bile drainage. Any more doubts, please? Okay. We will go to the next topic, that is pancreatic tumors. Tumors of the pancreas, the classification: tumors of exocrine pancreas. So there are two types of glands in the pancreas. One is the exocrine glands secreting the lipase, amylase, chymotrypsin, ribonuclease, elastase, etc. Then other is the endocrine tissue. So the alpha cells, the beta cells, the gamma cells, the D cells, VAP cells, etc. So the tumors can be classified as tumors of the exocrine pancreas. That is again classified as tumors of the head of the pancreas. There is about 70% of the tumors arise from the head of the pancreas. So again, they are classified into tumors from head proper and tumors from periampullary region. So head proper means the mass arises from this area. We call this as the tumors from the head proper. Periampullary region means the tumors arise only from the around the ampulla of water. The ampulla of water is situated with the confluence of the pancreatic duct with the bile duct. So that will traverse through the duodenal wall and open onto the papilla of water. So it can arise in the ampulla or surrounding the ampulla. That is what is called periampullary tumor. So this periampullary tumor can be arising from the duodenal mucosa around the papilla, or it can be from the common bile duct, lower end, or it can be from the pancreatic duct. So it can be from the duodenal papilla, ampulla of water, lower end of CBD, and duodenal mucosa adjacent to the duodenal papilla. So any of these structures may be involved in this tumor formation. This is called periampullary tumor. Then tumors can be from the body of the pancreas, that occurs in about 20% of the cases. From the tail, about 5% of the cases. Then the second type of tumors are tumors arising from the endocrine pancreas. So they are only about 5% of the tumors. Physical classification: solid tumors and cystic tumors. Solid tumors, most of them are malignant. Cystic tumors, they are benign as well as malignant, both of them are present. They are serous cystadenoma. Already I told you, it is a benign, present in women, present with larger aggregations of multiple small cysts, appear like a bubble wrap. Mucinous tumors, they are classified into adenoma, mucinous cystadenocarcinoma, intraductal papillary mucinous neoplasms, they are described as IPMNS. These occur in the older women have potential for malignant transformation. They are mistaken for pseudocysts of the pancreas. This is the diagrammatic representation of various cysts connection with the pancreas. Already I told you, I have shown you this image. This is pseudopancreatic cyst. This is mucinous cystic neoplasm, which is a lobular cystic mass containing thick jelly-like mucus. And this is the bubble wrap type tumors called the serous cystic neoplasm. And these two are called the IPMNS. That means intraductal papillary mucinous neoplasm. So this will be the main duct producing a lot of thick mucus. When you are doing ERCP for a patient with a cystic mass in the pancreas, when you put a cannula into the pancreatic duct and when you find very thick mucus is coming out, then you suspect that the patient is having IPMN, that is intraductal papillary mucinous neoplasm. Sometimes that may be from the not from the main duct. A side branch may have this IPMN. So there is physical classification. Physical classification is into benign and solid and cystic masses. Cystic masses again serous cystadenoma and mucinous cystadenoma. In the mucinous cystadenoma, we have the mucinous cystadenoma and mucinous cystadenocarcinoma. Pathological classification: benign tumors and malignant tumors. Benign is serous cystadenoma, hematomas, that means like hemangiomas, lipomas. Then malignant tumors, they are adenocarcinoma, mucinous cystadenocarcinoma, anaplastic carcinoma. So this is the classification of the pancreatic tumors. So depending upon the type of glands that are involved, exocrine pancreatic tumors, endocrine pancreatic tumors. Physical classification: solid and cystic. Pathological classification: benign and malignant. Now we will study about the carcinoma of the pancreas. Incidence: 10 cases per 1 lakh population per year. This is statistics in the UK. Usually occurs in old age. Both sexes are equally affected. Etiology: smoking. Then familial, like mutations of gene BRCA2, chronic pancreatitis and hereditary pancreatitis, alcoholism. So most of the alimentary tract neoplasms, in the etiology you can mention alcoholism and smoking, then you will be correct in about 90% of the cases. Because they are so common etiological factors for the malignant neoplasms in the alimentary tract. Pathology: the macroscopic types, Skirrus type, that is usual, that is a common. Then medullary. What do you understand by Skirrus? Macroscopically, when do you call a mass as Skirrus tumor? When do you call a mass as medullary? In carcinoma of the breast also, macroscopically we will differentiate them into Skirrus type, atrophic Skirrus, medullary or encephaloid, like that. So when do you say a tumor is Skirrus? Dense fibrosis. So whenever a tumor is having very thick fibrous tissue inside it, it will be very hard in consistency. When you try to cut it, it grates on cutting. That is Skirrus nature. And what is medullary? there is a lot of cellular components. So there are more of the glandular tissue is there and less of fibrous reaction. So that is medullary. So out of these two, which carries good prognosis? Scarus. Why? Why? It indicates host response. So there is intense host response. That is why the scarus carries a good prognosis. The third variety is the cyst adenocarcinoma. So there are three macroscopic types of the neoplasm. The head of the pancreas tumors, that means this is the head of the pancreas. A mass will be there in the head of the pancreas. Because of its close vicinity to the bile duct, it causes obstruction to the bile duct at an early stage. That is why the patient will first present to you with the future of only jaundice. He will not come to you for the mass because the pancreas is very deeply situated. The patient has to come to you with the mass in the abdomen means it should be so much large that it could have caused obstruction to the duodenum as well as to the transverse colon. So by that time, the patient will have the symptoms of the vomitings, but not a mass. So the patient with head of the pancreas tumor will not manifest with a mass in the abdomen. Please remember that. So he comes to you with the features of jaundice. The jaundice is cholestatic jaundice. Periampullary tumors, they manifest as early obstructive jaundice because they are very close to the level of water. So they will be causing obstructive jaundice. May manifest as intermittent jaundice due to sloughing of the tumor. What is intermittent jaundice? So this is the duodenum, and here is the papilla of water, and here is the pancreatic duct, and here is the CPD. The mass arises from this region. So because of its close proximity to the terminal end of the bile duct, it produces jaundice. That we can understand. Now, this mass rapidly grows. Any tumor which rapidly grows out of the supply of blood supply. That means whenever a tumor is growing, it needs more blood. So where from the blood comes? Blood comes from the host. That is why the tumor cells secrete some hormones. These hormones will cause proliferation of more capillaries and blood vessels into the tumor. So there is angiogenesis factor. Some tumors cannot have that angiogenesis factor. That means they grow, but along with their growth, the blood supply from the host will not be sufficient enough for them. Then what do they will necrose. So this periampullary tumor belongs to that variety. So it grows and it is deficient of blood supply, it necroses. So whenever it necroses, the obstruction is relieved. So the patient will be relieved from jaundice. Again, the tumor grows and it causes obstruction. So like that, there will fluctuating attacks of jaundice, obstructive jaundice. So whenever a patient comes to you with such intermittent attacks of jaundice, what is the commonest thing you think of for such a patient? Intermittent attacks of jaundice. What do you think? The common thing, common cause. What about others? Only 2 or 3 are answering. Just I want to check whether you are following the classes or not. Intermittent jaundice, what is the commonest cause? I have seen only 2 answers. What about rest? No, cirrhosis doesn't produce obstructive jaundice first of all. Then healing and regeneration will produce only fibrosis. That's why it is a progressive jaundice. If jaundice occurs means it is a progressive jaundice. The jaundice will occur in cirrhosis only in the late stages, not in the early stages. When hepatic insufficiency sets in, then only jaundice will be there. That means in child's B grade and C grade only there will be jaundice. In A grade, there will not be jaundice. So the intermittent jaundice, the commonest cause is stone in the common bile duct. The next common cause is periampullary tumor. Yes, tumor falls off and regenerates. So that is the periampullary carcinoma. Then tumors on the body and tail of the pancreas. Because of its deep position in the retroperitoneum, the patient manifests very late as a lump or pain in the back and usually metastases widely by the time the patient presents to you. Spread of the tumor. Locally, the head tumor spread to the common bile duct, to the duodenum, superior mesenteric vessels, and portal vein. So all the nearby structures are involved by the head tumors. Body tumors involve or infiltrate to the stomach, transverse mesocolon, splenic vessels, spleen, and retroperitoneum. When you make a wrong answer, don't repent. Actually, you should feel happy. And you will not repeat a wrong answer in the examination. If you commit wrong answer here, that's very, very, very welcoming, because you will never repeat such answers again in the examination. So that is why be bold and free to answer. Don't be inhibited, thinking that if you make bad answer, people will think bad about you. So no one will think anything about you. Once you say something correct, it is okay. Even if you tell something wrong, it is not at all bad. It is good for you. So don't feel bad, my dear friend. Okay, the body tumor spread to the stomach, transverse mesocolon, splenic vessels, spleen, and retroperitoneum. So these are all the lymphatics and lymph nodes. That means all the vessels like gastroduodenal artery, pancreatoduodenal, superior and inferior. Around them, the lymph nodes are there. Then all the lymphatics, they drain to the lymph nodes around the celiac axis. So all the lymph nodes will go to the celiac lymph nodes, and as well as they will communicate with the lymph nodes in the porta hepatis. The body and tail nodes, they will have tumors, they will drain into the lymph nodes situated along the splenic artery, and as well as lymph nodes situated in the hilum of the spleen. So head tumors, they drain to lymphatics along the superior pancreatoduodenal vessels, along hepatic artery, nodes in the porta hepatis, and celiac plexus of lymph nodes. Then along inferior pancreatoduodenal vessels, they will drain to the nodes situated at the origin of the superior mesenteric vessels. The body and tail tumors, they drain along the splenic artery to the celiac lymph nodes. The celiac lymph nodes and superior mesenteric lymph nodes, they drain ultimately to the thoracic duct. From there they go to the left supraclavicular lymph nodes. Blood spread occurs late in carcinoma of the pancreas. It occurs to the liver. Peritoneal implantation will be there producing ascites. So that is about the pathology of pancreatic tumors. Then we'll discuss about the clinical features of the pancreatic tumors. Features of cancer pancreas. Just like any cancer in the alimentary tract, the patient may have anorexia, asthenia, and anemia. Painless, progressive, persistent jaundice in 85% of the cases. This jaundice is due to head tumors causing obstruction of the common bile duct. The body tumors also can cause jaundice by secondary lymph nodes in the portohepatitis, because the lymph nodes draining the body of the pancreas, the tumors from the body of the pancreas can go to the lymph nodes around the portohepatitis, and they can cause obstruction to the common bile duct. And there may be intermittent jaundice. This is there in periampullary carcinoma, which I have already discussed with you. There will be enlarged gallbladder due to Corvider's law. Of course, because there is a very important law which is very commonly asked in the examination, I am asking you again here, what is Corvider's law? What is Corvider's law? Okay. If in a jaundiced patient, the gallbladder is palpably enlarged, it is not due to stone in the common bile duct, because the stone has originated from the gallbladder, which gets fibrous due to chronic inflammatory changes. So what you said is correct. So, but I said the whole statement. So stone in the gallbladder, stone in the common bile duct means then because of the fibrous gallbladder wall, though there is an obstruction of the common bile duct, the gallbladder is not enlarged. If the obstruction of the common bile duct is due to a tumor, then the gallbladder is very much distended, because proximal to the obstruction there will be increased pressure, and that pressure causes the distension of the gallbladder. So this is Corvider's law. So the main manifestation for the patient with jaundice, with pancreatic head tumors, is painless, progressive, persistent jaundice. He may get pain in epigastrium, radiating to the back, relieved by stooping in case of tumors arising from the body of the pancreas. because body of the pancreas tumors, they do not manifest with jaundice in the early stages. They manifest jaundice only when there is lymph nodal spread to the porta hepatis and causing obstruction there. So during that time, they may infiltrate to the muscles in the back. So that is why the patient gets severe pain in the back, and that is relieved by stooping. And the tumor may infiltrate the surrounding viscera and may cause obstruction. It may infiltrate to the pancreatic duct, producing diarrhea or steatorrhea because of exocrine deficiency. It may infiltrate to common bile duct, producing hepatomegaly and jaundice. It may infiltrate the duodenum, producing gastric outlet obstruction with vomiting and visible gastric peristalsis. It may infiltrate the splenic vein, produce splenic vein thrombosis, producing splenomegaly and fundal varices. Clinical features due to secondaries. There may be hepatomegaly due to multiple secondaries in the liver, ascites due to peritoneal implantation and peritoneal secondaries, mass in the abdomen or pelvis. This is uncommon. In the pelvis, why there is a mass? Tell me. We're talking about tumor in the pancreas. So a patient of carcinoma of the pancreas, how can they manifest with a mass in the pelvis? And how are you going to examine this mass? How are you going to feel this mass? Do you know or not? If you don't know, I will explain. Okay. Any neoplastic, any malignant neoplasm arising from the organs in the abdominal cavity, any organ, be it stomach, colon, pancreas, small bowel, hepatoma, anything. So these tumors in the late stage, they will spread from the mucosa, they transgress the wall thickness, then they come to the serosa coat. Once they come to the serosa, their tumor cells, they will exfoliate into the peritoneal cavity. These exfoliated tumor cells, what they do is they cause implantation over the peritoneum and cause ascites. And also, these exfoliated tumor cells, by gravity, they go downwards. And all the tumor cells, they collect in the pouch of Douglas or rectovesical pouch. And there they form a mass. Then, so any patient of suspected visceral malignancy of the abdomen, if that patient comes to you, if you do distal rectal examination, you will find a thick shelf-like mass in the anterior wall of the rectum. That means you are feeling that hardness from the rectovesical pouch mass. So you will appreciate that mass in the pelvis by distal rectal examination. There is a sign for this. So when you feel the mass in the anterior wall of the rectum as a hard shelf-like, what do you call this? What is the sign called? There is a sign for this. Bloomer's shelf. This is called Bloomer's shelf. Yes, this is called Bloomer's shelf. Very good. I hope you understood the pathogenesis. The ascites is because I told you when the tumor comes to the serous coat, the tumor cells will exfoliate they will drop off from the tumor surface. And these exfoliated cells, they will go and fall diffusely over the peritoneum. And they develop into small tumor masses. Because of these tumor masses, the peritoneum will get the exudate, the exudative type of reaction from the peritoneum, and it produces a lot of protein-rich fluid into the peritoneal cavity. Enlargement of the left supraclavicular nodes. Already I explained to you how an abdominal malignancy can produce mass in the left supraclavicular fossa. What do you call those lymph nodes? If there is a malignancy in the abdomen and patient comes to you with mass in the left supraclavicular fossa, yes, good. They are called Virchow nodes. Pulmonary features due to consolidation, atelectasis, or effusion. That means whenever pulmonary secondaries are there, these manifestations can be present. Then miscellaneous features. Sometimes patient may get multiple places thrombophlebitis. This is called the thrombophlebitis migrans or polythrombophlebitis. So this can occur in the carcinoma of pancreas, the carcinoma of colon, and carcinoma of the stomach. This is called Troisier sign. There is one more name for the Virchow nodes sign. They are called Virchow nodes. Clinically, they are called by a sign, a name of a sign. What is that name for that sign? When Virchow nodes are palpable, what do you call that clinical sign? What do you call that clinical sign? Do you know the sign or not? No? This is called Troisier sign. Of course, double R is not singular only. With thrombophlebitis migrans, it is called Troisier sign. So you will get confused between these two. Be careful. Then patient may come to you with diabetes mellitus in very large tumors infiltration in the pancreas. Investigations for a case of carcinoma of the pancreas. Liver function test, namely, because 85% of the patients of carcinoma of the pancreas, they come to you with the symptom of jaundice. That's why you must do the investigations for the jaundice. So what type of jaundice the patient comes to you? With what type of jaundice the patient comes to you in carcinoma head of the pancreas? What type of jaundice? Yes, very good. Can you tell me the stepwise investigations? So step 1, what investigations you do for a patient with obstructive jaundice? First is clinical examination. Mention 3 or 4 main clinical features of obstructive jaundice. First is clinical examination. When do you suspect obstructive jaundice clinically? Tell me the clinical manifestations of obstructive jaundice. Tell me 4 or 3 points. If you want to speak, I will give permission to your mic and you can speak. Yes. So put together, all of you have mentioned the 4 important signs, 4 clinical manifestations: deep jaundice, pruritus, clay stools, dark urine. So those are the manifestations with the patient comes to you. So clinically, you check for those points. If any one of them is present, then clinically it is suspicious to be obstructive jaundice. Then what you do? What is the next step? Clinically, it is obstructive jaundice. What is the next step you do? Biochemical investigations. Wonderful. Biochemical investigations, what do you do? Of course, I have mentioned here. So you examine for the bilirubin, alkaline phosphatase, and urobilinogen. So already we discussed many number of times about these things, so I am not going to repeat it. So biochemically, it is obstructive jaundice. Then what is the next step? Very good. Ultrasound scan. If it is obstructive jaundice, what do you find in ultrasound scan? On ultrasound scan, what do you find if it is an obstructive jaundice? Whatever may be the cause, whether it may be due to stone or it may be tumor, what do you find? Yes, the most important thing you have to look for on ultrasound scan is for dilated bile ducts. So dilated intrahepatic, dilated extrahepatic bile ducts. So that is the most important factor you have to look for. Gallbladder may be normal or distended in case of tumors. It may contain stones in case of stone jaundice. So the most important factor you have to look for is dilated ducts. If the ducts are dilated, means it is definitely a case of obstructive jaundice. What is the cause for obstruction? We have to go for next step. So what is the next step? So you have done ultrasound scan. There is IHBD and EHBD. IHBD means intrahepatic biliary dilatation. EHBD means extrahepatic biliary dilatation. So there is IHBD and EHBD. So what other next investigation you go? Next step is not the CT scan. Next step will be whenever there is dilated bile ducts, yes, you have to go for ERCP. ERCP will demonstrate the cause of obstruction, the site of the obstruction, and if necessary, you can relieve the obstruction. So next step is ERCP. Okay, you have done ERCP. You found the obstruction at the terminal end of the bile duct, and the obstruction is irregular due to irregular shadow. So your conclusion is neoplasm. So now what do you do? Obstruction is at the terminal end of the bile duct, and the obstruction is due to a irregular narrowing of the bile duct. So what do you do? Very good. You go for endoscopic ultrasonography or you go for CT scan. CT scan will show you mass in the head of the pancreas or periampullary tumor. You can make it out. Or better, you can buy endoscopic ultrasonography. The advantage with the endoscopic ultrasonography is you can even take the FNAC. So with FNAC, you can even have the histopathological diagnosis. So very good. You are following the classes as well as you are studying at home. I am very happy. Wonderful. So for any case of cholestatic jaundice, for example, if you are given a question on stone in the common bile duct, investigation of a stone in the common bile duct. So you can write down all these investigations and you deviate after ultrasound scan. What features will be there in the stone? What other investigation you will do for the stone? For tumor, again same investigation. For stricture of common bile duct, same investigation. For cholangiocarcinoma, same investigations. So all these things you can just put it under the heading of investigations for a case of cholestatic jaundice. So any cholestatic jaundice means you must follow these steps. Don't forget the clinical. First, clinical examination, clinical symptomatology. So the 4 symptoms. Then biochemical investigations. And clinically you have to mention about the Corvallis law also. Then the biochemical investigations. Then ultrasound imaging. Then ERCP. Then CT scan. Then endoscopic ultrasonography. So these are the things you do in the case of cholestatic jaundice to evaluate the cause and nature of the obstruction. So ultrasound scan, it may show you the presence of the tumor. It shows pancreatic dilatation and bile duct and gallbladder dilatation. If liver secondaries are there, you can make out liver secondaries. Similarly, if ascites fluid is there, they can make out ascites. CT scan, contrast enhanced spiral CT scan is the ideal investigation. It gives better information about the mass and local infiltration. Lymph nodal hepatic metastasis can be demonstrated well. Duodenoscopy will help you to see for the periampullary growths, and you can take a biopsy. Then barium meal. This is not being done nowadays. Barium meal. The PAD sign and reverse 3 sign are there. So if carcinoma of the pancreas means the duodenum will be stretched. So it looks as if a pad is being kept here. In periampullary carcinoma, you will see the reverse 3 sign. So the duodenum will be like this. Hypodenumography, this is also not being done nowadays. Endoscopic ultrasonography, so this is a wonderful investigation for detection of small tumors and for evaluation of T stage of the tumor. And of course, you can take FNAC from the tumor mass. Pancreatic secretory studies and cytology for malignant cells, then ERCP. So these are the investigations you do for a patient with cholestatic jaundice and suspected carcinoma of the pancreas. Management, it depends upon the site of the tumor, whether it is the head of the tumor, head of the pancreas, body of the pancreas, or tail of the pancreas. Then operability of the tumor. So operability is checked by infiltration and metastasis. Then fitness of the patient. Signs of operability. I hope all of you know about operability and inoperability of a tumor. Do you know it or not? If you don't know it, I will explain it. For all the neoplasms, when you say surgical management, if it is operable, we will do like this. If it is inoperable, we do like this. That's how we describe. So do you know about operability and inoperability? No. Okay. Okay, I will explain. So in general, I will explain to you what is meant by operability and what is meant by inoperability. Any tumor, to begin with, it starts as division of cells and forming a mass. So it forms like a mass. Then what happens? It spreads to the surrounding, invades to the surrounding tissues. First, it starts in the mucosa, then it passes across the wall. So it goes into the, crosses the basement membrane, submucosa, muscular layer, serous coat. That means up to serous coat, it is within the wall of the gut. After the serous coat, what it will do? It will go and infiltrate into the surrounding organs. For example, pancreas is there. Pancreatic head masses, for example, they will go and infiltrate into the superior mesenteric vein or portal vein, or they will infiltrate the duodenum. They will infiltrate in pylorus of the stomach, or they will infiltrate in transverse colon. So, what are all the organs into which it can infiltrate? For that, you should have some knowledge about the relations of the pancreas. So, all the adjacent organs, it can infiltrate. What is meant by infiltration? The tumor cells will pass from the pancreatic head into the stomach, and there will be thick adhesion. This thick adhesion between the pancreas and stomach is because of the tumor mass. So the tumor mass goes into the depth of the stomach or depth of the duodenum. So there is local infiltration. Then it spreads into the lymphatic vessels and go to the lymph nodes. It spreads into the capillaries. From there it goes into the blood spread. So any tumor can spread locally, can spread by lymphatics, can spread by bloodstream. Why we do surgery? We want to remove all the neoplastic tissue in the body. So the patient will be cured of the disease. So when can you say that the patient is cured? When you can remove the tumor in totality. That means, for example, it is appearing from the pancreas, I suppose. It is arising from the pancreas. It has infiltrated the duodenum also, let us suppose. It has not gone beyond duodenum and pancreas. It is there only the duodenum and pancreas. Then what you can do? You remove duodenum and pancreas. Because there is nowhere else in the body the tumor cells are present. So if you remove duodenum and pancreas, the patient is cured. For example, the mass is very small, but it has gone into the liver. It has gone into the lung. What does it mean? When it has spread into bloodstream, that means it has metastasized to some other viscera by blood spread, not by direct invasion. Means that in the blood there are many tumor cells floating. Even if you remove this mass, the patient will get metastasis again in other places and they will kill the patient. So even after doing a very big operation to remove this mass, if secondaries are there in the liver or in the lungs, the patient is not going to survive. So operability means whenever the tumor is confined to the organ of its origin, without spreading to the adjacent viscera, without spreading to the lymph nodes, without spreading to the distant organs by bloodstream, then it is called a operable tumor. It is not by size. Of course, size also counts. So, inoperable, any tumor which is having local spread. Local spread means spread to the contiguous organs, or dissemination by lymph nodes and dissemination by bloodstream is called inoperable tumor. So whenever you tell surgery for a tumor, the first thing you say whether tumor is operable or not. Number two, whether the patient is fit for surgery or not. hope you understood about operability. So inoperable tumor means that the patient is having secondaries in the liver, secondaries in the Douglas pouch, or secondaries in the peritoneum, or secondaries in the lung, brain, or bone. Then we are not going to do a curative resection. We don't do big resection for this patient. After, if there is disseminated metastasis by bloodstream, if you give chemotherapy, some of the tumor cells can be inhibited, but you cannot assure any cure. So the chemotherapy is mostly essential if there is no development of the metastasis. If you suspect some blood floating cells are there without any metastasis, then chemotherapy will be helping to cure. So chemotherapy cannot cure the secondaries. They can withhold the growth for some time, only for some time. That's why they are called palliative mode of treatment. The patient dying within 4 months, so he will be dying after 2 or 3 months later. So that is the use of chemotherapy, but chemotherapy is not going to cure the tumors. It will stop the growth, or it will control the growth for some period. So if there is any established secondaries in the liver, lungs, bone, etc., chemotherapy will be given. But that case is called as inoperable case, and you don't plan for any big resection. Resection means curative resection. Curative resection means you will remove the tumor mass along with the organ and surrounding tissues. At least 2 or 2.5 centimeters clearance margin will be there around the tumor mass. So that much of tissue has to be completely removed. Then it becomes a curative resection. So it is also called as en bloc resection. For example, you are removing pancreatic tumor. So curative resection means what do? You will remove the pancreas, you will remove the duodenum, you will remove the pylorus of the stomach. So all these things are removed. For a 2 centimeter mass in the pancreatic head, you are going to remove all the surrounding organs also, because there will be lymphatic sharing by these organs also. The pancreatic lymphatic drainage, duodenal lymphatic drainage, pylorus lymphatic drainage will go in the same path. So what we presume is the tumor cells might have spread to the lymphatic vessels, though they are not gone to the lymph nodes still, but we presume that they may be in the lymphatics. So if you remove only pancreas, the tumor cells that are there in the lymphatics of the stomach or in the duodenum may come back and then may implant in the duodenum and may cause duodenal malignancy. So that's why we want to do a wide extirpation of the tumor. So the tumor plus 2.5 centimeters of surroundings along with the common lymphatic channel pathways viscera. So they will be removed in this procedure. That is called as radical operation. For a small tumor, you are going to remove many organs around it. For example, breast is there. You remove breast, you remove pectoral fascia, you remove the skin, areola, nipple, and you go on to the axilla, remove all the fat and then all the lymph nodes and clear the axilla. That is what's called the radical mastectomy. The true radical mastectomy means you remove the pectoralis major muscle also. So for a small tumor in this breast, you are going to remove so much of mass. So this is also called block dissection, because you don't cut the lymph node tissue as one piece, the organ as another piece. You remove the tumor along with the organ that is there from which the tumor is arising, and the lymphatic pathway, lymph nodes, everything must be removed in toto. That means you are removing a block of tissue of tumor and tumor draining lymphatics and lymph nodes. So that is what you plan to remove. So that is why it is called a radical dissection, or also called en bloc dissection, or also called as curative resection. So curative resections are done only for operable tumors. For inoperable tumors, that means where they have disseminated to lymph nodes, where they have disseminated to other viscera, where there is local spread to the surrounding organs. Even though you do such a big resection, the patient is not going to have the survival benefit. That is why they are called as inoperable tumors. So, with this generalization of operability and inoperability, I will continue this discussion on the carcinoma pancreas management in the next class. Okay? Any doubts? So tomorrow we'll have the class on these neoplasms, then endocrinal neoplasms, then some topics are left behind in the bile duct diseases. So whatever may be the time, we'll finish up those things also tomorrow. Is it okay? Yes, after the pancreas, we will go to the topic of disease of the stomach. Of course, stomach chapter is a very big topic. That's why we'll divide into two parts, peptic ulcer disease and neoplastic disease. So we'll discuss separately. Yes, MRCP also is useful. Instead of doing ERCP, you can do MRCP. But when you do ERCP, there is a benefit of doing stenting. If there's common bile duct obstruction and obstructive jaundice, then you can do stenting also. But for MRCP, you can only make diagnosis. Some surgeons, they don't want stenting before surgery. Some surgeons, they want stenting before surgery. So there are pros and cons. As an undergraduate student, they are not necessary for you to know. So you can just mention instead of ERCP, you can mention MRCP also. Okay. Wish you all good night. See you tomorrow at the same time. Okay, bye. Thank you.